Thanks for having me here. I come east from Dallas frequently. I can tell you I have not been to Tyler yet, so sorry about that too. But this is it's good to come through and drive. And what do I walk into? One of my patients that cared for how many years ago now? 12. Yeah, yeah. So always a nice surprise. So I'll jump right into it. I think I was probably a little ambitious talking about in terms of what we were going to talk about today. But I'm unapologetically direct, and so we'll go there. And I'm also pretty informal. Ask questions. This is all about learning and sharing ideas. Every time we go someplace, that's what we should be doing. So don't be bashful about it. I said vascular malformations in an hour. We'll go through some things, and I'll hopefully share some fun stuff and good ideas. But use your brains. I may pick out people and ask questions if you have them as we go through. Keep going. So these are disclosures which we're required to do. And this is a fun quote for me. And this is one of the things I like about this cerebral vascular disease in general. And you'll see I use that term because I just don't like the fact that we just talk about stroke all day. Right? We take care of, there's a lot of things that cause stroke, but there's a lot of things that are just not thrombectomy, right? And what's happened over the last 15 years is thrombectomy's taken center stage just like CABG and stent interventions did in cardiology years ago. But the fun part about this type of disease that we treat is we can think about it, things change, how do we strategize, and there's so many other things that we can do now. And just in my short career since the late 90s, things have changed a lot. At one point, every 6 months there was something new, right? We've slowed down a little bit, but now we're starting to combine the new stuff with the old stuff and having fun with it. So when we talk about vascular malformations, we're talking about AVMs. We're talking about cavernomas. We're talking about venous angiomas. Telangiectasias, I'm not going to get into much. That's a lot of genetics and things that we'll see. But these are terms that everyone will hear in the clinics and the ERs, will confuse you from radiology reads. But briefly put, cavernous malformations, cavernomas, we try to make things, not too many words. Venous angiomas, I just call them funny thumbs. And this was one of my mentors said, just think about it that way, because more times than not, the more you look at a funny thumb, the more you worry about it, right? Just put it behind your back and go on to the next thing. So we'll talk briefly about what those are, and we'll get a little bit more into what the more therapeutic options. But these are commonly referred to. Our clinic, I probably see a venous angioma referral once or twice a week, right? And I only have a clinic a day and a half a week. Right, so those come because they're red on radiology, and patients have a headache, and they look weird, but they are is a normal way, a weird looking way for the brain to drain. So if venous angioma comes up, more often than not, there's nothing that we're going to do about them, and that's why I start with them. Unfortunately, we learned there was nothing we should do about them because people started taking them out when we started doing angiography, and people had strokes. Right? They're draining the brain. A venous stroke you can get through, a little bit better than arterial stroke, but a stroke's a stroke. There are times when venous angiomas get very interesting, and this is probably the most interesting one I've had over the last 20 years. Was a young woman. She was 19 at the time. She's 38 now, and every time she got on a roller coaster, she got vertigo. Right, and some people, that's just what they do, right? But in her case, vertigo, headaches, and then her face started twitching. And when her face starts twitching, that's a hemifacial spasm, which is something that we talk about what's going on with the facial nerve. This is a picture of her venous angioma, which is here. Can everybody see that arrow there? And that venous angioma in surgery is going right up under the facial nerve, right? And because of that, facial nerve is right next to the eighth nerve. There's your vertigo. There's your hemifacial spasm. And frankly, I'm not taking that out. I'm not putting the clip on it. You can't bypass it. And we shrunk it. Unfortunately, it comes right back, right? So she's 38 now, and she knows to caution people if they think she's winking at them, right? That's about all we can do, right? But she's done well. She has kids, and I've watched her through a period of time. things about the angiomas that get confusing are sometimes patients show up with seizures and you have a big vein like this and there's a little bit of scar tissue around it. Is that a problem? Not so much. But what you should look for when you hear about a venous angioma, the next thing you're thinking about is there a cavernoma? Right? About 70% of the time you're going to have a venous angioma is going to be associated with a cavernoma, and you think we'd be smart enough to figure it out by now. We don't know why. Right? But they're there, and we worry about them more, okay, because when we take cavernomas out, and we'll talk about it, then we have to leave that intact circulation there. This is a classic picture of a venous angioma on an MRI when you see them, and you can see why they're called the caput medusa, or the medusa head is the other thing we hear about, right? Because there's your snakes, right? So again, funny thumb. Is there a cavernoma there? Can it be associated? That's your venous angioma in a nutshell, right? But they are very, very common, so I figured we'd start off with something straightforward, and then kind of go into the cavernomas. The cavernomas are they're also very interesting lesions. Okay, cavernous malformations are the same thing, and these are for some reason where's Dr. Rulin? He walked out here, but the radiologist and the pathologist they're always eating, I guess, when they're doing stuff, and these are popcorn lesions for some reason. So that's what, if someone says a popcorn lesion, I guess, but what cavernomas are is, I like to explain them as they're basically spleen in the head. All right, there's a term called hamartoma. Hamartoma means normal tissue in a weird space. And if you think about it, this is a spleen tissue that ended up in the head, and unfortunately shouldn't be there. And if there's any kind of blood, you get issues with the blood and the irritation. So this is a very classic looking, I tried to get something that looked like popcorn, but I describe them, popcorn on an MRI, berry in the clinic. Patients tend to understand cavernomas when you talk about them, like a raspberry, a blackberry, a boysenberry, some sort of a seed pocket fruit. Because if you think about it that way, then every time one of those little pockets leaks, cavernomas don't rupture, right? So bleeding from a cavernoma is not happening, right? And that's a very common, patients come into the clinic, they think they're bleeding. We're bleeding, you wouldn't be talking to me, right? But you bled, that little seed pocket popped, it irritated the brain. I tell patients all the time, you could urinate on the brain, and it's less irritating than a little drop of blood on the brain, right? And we know that because blood is not supposed to be there, right? And no, neither is urine, but it's a different discussion. So, right, but if you think about it that way, there's a randomness about how cavernomas present. If there's a little bit of a bleed, a leak, right, and it's been happening over time, sometimes it can be headaches, and that's most of the clinic visits you get these days are headaches, okay, that happen to get an MRI. But they can also show up with seizures, because the irritation of the blood as it gets around the cavernoma, that could cause seizures. And then the deficit, where is the cavernoma? What's it doing? Okay, this is a patient who she was also young, right? Usually slight predominance in females, but this is the carotid artery, but the optic nerves are right here. Okay, so the carotid artery is coming up this way, and what you saw here is this is the optic nerve, which is bruised. She had some visual deficit. This was a classic one for the ER. If you get somebody with a hemianopsia, sudden onset, and a headache, the first thing the ER doc's going to think, or should think, is that there's a pituitary problem. Right, so everybody thought she had a pituitary problem. This is in the region of the pituitary gland because it's between the nerves, it's lifting things up. But pituitary tumors don't look like popcorn, okay? And so what we did was resected that and took that out from under it. You can't leave her without a deficit when she presents with it, but it's gone, and again, we follow up. Cavernomas in the brain cause seizures, get them out. Okay, cavernomas in the brainstem cause a problem. It better be close to the surface because it's real hard to get them out. Okay, and I'm moving through this just so to think about it. But most cavernomas are going to be in the big parts of the brain, right? Because that's where most things are. You get spinal lesions too, though. And a lot of times we don't catch those. Common things in the spine are going to be discs and radiculopathies, things like that. But they're cavernomas in patients, especially in patients who have a familial syndrome. Most cavernomas are by themselves, okay? And so if you see one, it's probably bad luck, right? If you see a whole bunch of them, it's probably familial, okay? So these are familial cavernomas, and it's unique in our part of the world because you see there is a predilection for familial cavernomas in the Hispanic American population. Right, so a little bit higher risk of that. So we will see a lot more families. I would say of the families that I follow, it's probably half and half, probably Caucasian and Hispanic heritage. Okay, but there are, and so we do know there are genetic causes to cavernomas. We send them to the geneticist, but it's more for the kids, right? To know if your 2-year-old's having headaches and you have this gene, then it's probably worth sedating them for an MRI. Right, if your 2-year-old's having headaches and crying, and there's not the gene, maybe you don't sedate them and put them through an MRI. But there's not a whole lot we're going to do genetically, right, to fix things yet. But what we read the other day, we just created a dire wolf. Did y'all get that? So there's a lot of things we're going to be able to do soon. So when we talk about the biggest concern for cavernomas, again, is the brainstem. Right, brainstem cavernomas you can't go through the brainstem to get to it without causing a problem. And as you might guess, if this is the pons here, we're sitting in the midbrain, we can get those out, but you better make me, right? Because in this case, this is where we can go in and get this right to the surface of the brain. Once you're in the cavernoma, you're not causing a problem, but trying to get to it is the issue. Headaches, not so much. Okay. Weakness. Brainstem is a high-priced real estate. Weakness, numbness, cranial nerve difficulties, all that stuff's clumped up into one. You're thinking brainstem or medulla, pons, midbrain, something like that. But more, and it used to be our rule was 3 strikes and you're out, right? Because every time you would have a symptom, bleed, you got a third chance getting worse, third chance of recovering. So by that 3 times, it might be worth going after it. But it really depends on how the patient presents and how bad they are the first time, right? Because our microsurgery is better, our imaging is better, and so we can get to them. Patients with brainstem cavernomas are frequently more symptomatic than having repeat hemorrhages, right? So every time they have a symptom doesn't mean they bled. It's just because it's in a bad spot and it's a very sensitive spot to get to respond to. So the brain is going to, and they're strokes. Right? This is blood in the brain. So when we say if you're overheated, underhydrated, underrested, strokes come back. Right? It's not the stroke that's coming back, but it's the symptoms and the damage that's being reactivated. Cavernomas are no different. Okay? So a lot of times what we're trying to figure out is what symptoms are. These are very aggravating, anxiety producing for young patients who are diagnosed with them, especially women who are in childbearing age, right? I have 3 patients right now that we're working them through. The visits that I have in the clinic for patients with cavernomas are counseling sessions, right? More than actually talking about surgery. But they typically don't grow. They can rebleed. You will have symptoms. Put it on your iPhone. Get a picture of it. So when you go to the emergency room, we can say this is where we're starting our conversation from, right? As opposed to, oh my God, they bled, $20,000 ambulance ride to the next hospital, right? There's nothing that we're going to do, right, unless there's a significant new deficit. We're going to calm them down. We're going to give them steroids, and we're going to talk about what our next steps are going to be. Okay. So seizures, same, like many things, but like I mentioned at the beginning of talking about these, and if you present with a seizure with a cavernoma and we can get to it, the best thing to do is get the cavernoma out, right? Because that's the best chance to decrease any need for increasing seizure medications over the lifespan of a young patient. Okay? And most of these patients, if it's deeper and we got them on seizure meds, almost half of them we can control. Okay, so we've talked about this briefly, but I think the take home when we talk about any neurosurgical management is how often have they bled, and do we want them to have one more down step on that stair step, right? Or are there seizures, right? Those are the two first things that we're thinking about when as a neurosurgeon talking about what are we going to do about a cavernoma. Okay, if you're not a neurosurgeon, think about those things. How many times have you bled, right? Do you have your own pictures to go with, and that's really important for patients over time. And then how are your seizures controlled? Are you taking your seizure medication? And frankly, are you driving, right? Because you're not supposed to be. That's our 90-day rule, right? So, so radiosurgery for cavernomas is something that's pretty controversial. We at UT and other places that I've been don't suggest that radiosurgery be performed for cavernomas. It sounds like a great idea. It's a deep thing. I'm telling you, I can't do anything about it. But one thing, the deep ones I can't do anything about, those are the areas that are more at risk if we're going to nuke them, which is pretty much what radiosurgery is, right? So, and then the problem with the cavernoma is if you nuke it, you can't tell what it did. They look the same 10 years later. So all we're waiting for is, do they have another symptom or not? Unfortunately, if you have more gamma knives at your facility in the nation, you believe more that gamma knife works for cavernomas. You get me? Right? So, but generally speaking, there is some data suggests that seizures can be controlled with radiosurgery. Outside of that, there's only 2 or 3 places in the country that really advocate for radiosurgery for cavernomas, and there are probably 3 or 4 gamma knives in those facilities. Okay, so we'll talk about it, but we typically don't talk about radiosurgery for cavernomas because of the difficulty with them. One piece of information which is useful if you see patients with cavernomas, and it's very controversial or not controversial, but very highly discussed in the clinics, is anticoagulation. Okay, can you take aspirin? If you have a cavernoma and you get AFib, can you be on Eliquis, right? Newer data, especially with some of the genetic discussions that we're having, is suggesting that actually anticoagulation can decrease the incidences of cavernoma symptoms, right, and rupture. Why? There's an anti-inflammatory, antithrombotic component between inflammation and thrombosis that we think makes a difference. If you need Eliquis, any of the DOACs for AFib, your problem is more likely the AFib than it is worrying about the cavernoma bleeding. Take it, right? Most of my patients now are on aspirin to have cavernomas because of the newer data, right? It's okay. Pregnancy and cavernomas. Big thing about cavernomas, we didn't know about them except for autopsies until early 70s because we had CT scans, right? You can't see them on an angiogram. If you can't see it on an angiogram, the blood supply is very minimal. How high is your blood pressure have to be to get all the way out there to cause a problem, right? So there's no association between the blood thinners, blood pressure spikes, things like that, and bleeding from cavernomas, right? So they can be very bad lesions to deal with, very chronic lesions to deal with, but treat the medical problem that you have with the cavernoma first before you start worrying about that, right? So it's not quite the funny thumb, but but treat your other problems. So, genetic testing we've talked about, and I won't go into that too much, but I think it's probably worth, when you have young families with cavernomas, it's probably worth running them through a geneticist just to get them, this is where you are, okay? More often than not, that's not an issue. So, I'm going to pause there just for a second. Any questions about what I'm talking about? And I'm trying to hit highlights and make sure people are it looks like everybody's awake so far. So, because when we start talking about malformations, most people, we worry about AVMs, right? Those are the ticking time bombs that aren't aneurysms. Those are the ones that are a little bit more complex to deal with. And what management of AVMs changed a lot with this Aruba trial. How many people have heard about the Aruba trial, or quoted in the clinics? So a few. So other than it's a place I'd like to be frequently, that was our first modern look at patients in a supposedly randomized trial to say that how do we manage AVMs with all this new technology we have, all these new devices that we have, all these abilities we have to not just go in there and cut it out. Is that the right thing to do? Aruba said medically manage is better than any kind of procedural treatment of an AVM. But what's important to look at, when Aruba first came out, they looked at patients for just, it says 33 months, but just under 4 years. How many people have an AVM for 4 years? Right? AVM is a lifetime disease. So if we're looking at things at 4 years, it gives you an idea, okay? But it doesn't necessarily say. So now we'll talk about that. But Aruba really changed. There's a lot of patients now being seen in the clinics with AVMs that are not getting referred to cerebrovascular physicians because Aruba said don't do anything. And of course, we're surgeons. All we want to do is cut, right? Right. So, but as I mentioned with the cavernomas, the counseling is important, right? And it's very hard to counsel somebody if you haven't taken care of what's bad. Okay. So what we did get from Aruba was a little bit better understanding about what's your annual risk, and we'll talk about this as we get into it. But that's why I call this post-Aruba, right? Another thing that Aruba is really important to understand about this trial, if we're quoting it, is the intent was good. The intent was to bring people together, talk about how do we manage AVMs, make sure all specialties are involved, but that's not what panned out. Okay, so what we ended up with was a lot of patients getting embolized, going through the groin and blocking off parts of that. Okay, some patients getting radiosurgery, but of the AVMs that presented, most of which were what we call low-grade, small, manageable AVMs, less than 5% of those actually underwent surgery. So surgery wasn't very well represented. Aruba happened a lot in Europe. And there's a big split. We've been a little bit more ahead in the U.S. about having surgical specialties and radiology specialties working together. But in Europe, I was in France. We don't have any clippers. That's what they say, right? Because they don't have. There's no surgeons who will operate on aneurysms anymore because the radiologists blocked them out. So it really wasn't that team approach that we need, and so we didn't get team results. And so I look at Aruba and I say, just don't get your AVM treated in Europe, right? But we did understand the natural history a little bit better. Just when we talk about parlance and when we're talking about AVMs and vascular malformations that are congenital, everyone mentions this Spetzler-Martin grade. How many people know what the Spetzler-Martin grade is? We ever talk about that? Good. Okay. So Spetzler-Martin grade, when you'll hear terms about AVMs, which are grade AVM, high grade AVM, low grade AVM. This Spetzler-Martin grade is worth knowing about because it's very, very popular since the 80s. But it only talks about how hard it is to take an AVM out. It's a surgical grading scale. So if someone's, and we'll see it, I don't know, Kurt, when y'all read, do you say grade 3, grade 1? Do you guys say that anymore? Or right, eloquence. So we're using great Spetzler-Martin grading criteria, and a lot of times when we read the results, then we talk about, okay, this is what this is. But with the way embolization has come along, we've started to use this grading system to talk about embolization, to talk about outcomes. It's surgery. That's it. Okay, but for briefly, 1s, 2s, and 3s, there's a lot we can do about them. 4s and 5s, probably not so much. Okay, and so it's helpful for that. And so when we start talking about Spetzler-Martin grades or just the grading of AVMs or treatment of AVMs in general, how old are they? Younger patients, because they're going to live longer than 33 months, right, have a longer time to live with AVMs and therefore will have a higher risk of bleeding. Okay, so we're typically a little bit more aggressive in younger patients. Okay, did they bleed already? Right, AVM bleeding risk from Aruba, from prior studies, annually it's about 2%, just for easy math. That doesn't mean 2, 4, 6, 8, 10, 12, right? It means in that year, 2%. Okay? If we want to talk about the risk of bleeding of an AVM over your lifetime, a fun one, an easy one to use is 105 minus your age. Okay? So if you're 20, you got an 85% risk of bleeding, right? if I'm telling you surgery has an 85% risk and you can run, you should, right? Okay, so most of the time we can beat a long-term risk, but it just depends on what that risk is and what the potential harm is. But if you bled before, you're likely to bleed again in the next 6 months. So once you bled, it's a little bit different. Once you get beyond 6 months, the bleeding risk gets back to that normal 2% or so we can get you through that. But how young did you bleed? How hard is it to get to? Okay, we use terms like eloquence, and then we debate that tons of times. And if it's in the left temporal lobe, all right, it's probably eloquent because that's dominant lobe and speech is an issue, right? If it's in the motor cortex, that's also. But outside of that, is vision eloquent? I think it is. Right, I don't want to lose my vision if I have to operate on someone or give a visual loss, but that's debated. But that gets to how well you can get to. So we can go through. There's a lot of different reasons to look, but for anyone who's not a neurosurgeon or an interventional radiologist that's working with AVMs, the most important thing is, did you bleed? Okay, and frankly, we see it. Did you see anybody when you bled that wasn't just the ER and rehab? Right, there are patients who get, they'll never see a specialist, right, because someone has decided based on Aruba, right, that they should be medically managed. So, did you see a specialist? That's important, okay? And then, if you don't have access to a specialist, depending on where you are, get them there. That's the most important thing. If there's a family member that you have with an AVM, did you see somebody that takes care of these on a routine basis? And do they have a team that they work with? This is this is a team approach to taking care of these. So if you remember nothing else about AVMs, and we'll get into some case looks in a minute just for that part, but surgery is always the most definitive. If they can be taken to surgery to get the AVM out safely with a low risk, that's where they should be. There's nothing that argues that. Right? Radiosurgery will always be the least invasive when one's cutting you, right? But is radiosurgery going to give you some sort of a fix, a cure? Because that's what we want to do over the patient's lifetime, okay? Embolization should always be considered adjunctive, okay? And what adjunctive means is it's going to help radiosurgery or surgery, okay? Now, everyone who's done this enough, right, has had some cures, all right? But we will usually say about 20% chance of that. What Aruba said is if there's a 34% chance of causing a disability if you're only embolizing because they were trying to cure them with embolization, you shouldn't go for cure with embolization. You're going to hurt somebody, okay? Embolization should help get you to a goal. And that's one of the things that happens is and we're pretty lucky in the U.S. to have overlapping specialties. But when you go Australia, France, Brazil, right, they're completely separate. Everybody's guarding their own stuff, and that's just not the way to treat, especially for AVMs. So we'll add to that part. Best for small for surgery, okay, we can get to them. 90% success rate at 3 to 5 years if you choose the right radiosurgery. It's pretty good, right, especially if you're not going to hurt somebody. But again, that 2.2%, and this is sometimes hard for patients to get, your annual risk is 2%, but it's not additive. Your lifetime risk is 105 minus your age, okay? And we kind of go through that part of it. So when we start talking about treating these, this one, and this is my quiz part. We'll see who raises their hand. So this is a 27-year-old lady. Right? She's a student. She was in Houston. She has her first seizure. This is a left-sided AVM. Her seizure is kind of a typical generalized seizure, but she starts off with right arm problems. Okay? So that fits, right? So this is the MR that she shows up with. The blue line is kind of approximate where the motor strip is, but the good thing about seizures, if there is one, is when a patient has a seizure related to a lesion, you kind of know what your deficit's going to be, right? So if I took this out, then I would talk to her about arm weakness because her seizure showed up with arm weakness, right? So this is an unruptured what's her bleeding risk over her lifetime? You don't have to do the math. What's the equation? Yeah, 105 minus the age, right? And so I had a guy a couple of weeks ago, and we talked about one of his risks might have been calculation, right? And he couldn't get that 105 minus your age, and I said, well, it's not going to be a problem then. We're good, right? So, so she has, but at 27, she's got risks there. When I show this, because you shouldn't, all this, we call this, this is flare change, all of this is swelling, right? And there's either she's had strokes, she has bled, or something's pulsating in there, okay? And if you look at this, AVMs typically are this kind of little salt and pepper stuff here. That's a big vein. And remember, an AVM is a nest of blood vessels with the arteries going in, low pressure, sucking blood into the vein. It's a low pressure system. Okay, veins don't like artery pressure. What they're going to do is dilate to get out of the way. And sometimes when they dilate, they do this and they bleed. Okay, so this is the angiogram. Okay, so unruptured young patient close to the motor strip. So let's call it eloquent. Okay, should we give her seizure meds? Raise seizure meds. Everybody's going to say, let her have seizures? All right, so, okay, all right. Seizure medications, right? That's the straightforward one. Should we take it out? It's small, right? She's young, right? Why wouldn't I take it out? If I do take it out, I can decrease that risk, right? Right? But if I do take it out, she'll have to take her seizure meds with her left hand, right? Okay, sorry, I'm direct. Sorry. So, right? But that's what we're thinking about, right? So, so I'm not super excited about taking this out, especially in the young girl, right? Embolization, go for cure, right? Right. We don't want to, and this is a pretty complicated AVM. All right. There's a lot of these are blood vessels going to it. This is the anterior cerebral artery making its way that way. You've got some blood vessels coming to it, not so much off of here. One thing to realize: these are normal sized blood vessels. Okay, those are big, and they're big because the AVM's sucking the blood in, and so the blood vessels are dilating as a result. So, in radiosurgery. That's our other option, right? We also have another option, is leave it alone. We can put her on seizure meds and leave it alone and have her take a risk. Okay? She wasn't having that, right? And if we have some options. So this is where this fluidity of thought we talked about. We've got all our options. My biggest concern is that big old honking vein that's sitting in the middle of the brain that's causing all that. It's probably causing the seizure and at risk for bleeding. Okay, and if I can get rid of that, then I've taken her bleeding risk down, supposedly, and then we might be talking about some radiosurgery over time, right? We're humans. We want to fix things. We're human Americans, right? We want to fix things real fast, right, and get right. Take your time. Sometimes we can shrink these things with radiosurgery enough to the point where surgery is not that hard. And she's young. She's got time, right? So we did all that and went through all that together, and we said basically, check. We're going to do seizure meds. We're going to do embolization to potentially take at least the flow to this vein down, okay? And then talk about radiosurgery. And we can either blast it at once or we can break it up over periods of time to take it down, okay? But that's a different lecture, right? So the reason this is a useful case to talk about is we used to always talk about going through the groin to embolize. Right, we're going to block off blood vessels to take down the flow to the AVM to make sure it doesn't bleed, maybe not so much flow to this aneurysm. But what if you went through the vein? Right, what if you went through the vein to take down the vein aneurysm or the varix that's here? Okay, 10 years ago, 15 years ago, that was anathema. You would not do that. Because an AVM, remember, it's pumping. You take the vein out, you just left the faucet on, but you closed the drain. That's it, right? So But nowadays, with the catheters we have, with the techniques, we can get in there and actually retrograde or embolize backwards. We don't want to do that all the time. But in this girl's case, what if we went through the vein, and this is the catheter which is coming up through the superior sagittal sinus across the vein here, and then you can see that's injecting into the varix. So we got the catheter into the varix, so we could then go and just coil it, right? So now we've taken that part away, and then you don't notice this, but these little pluses here, these are the frames that we use to localize the radiosurgery. So we put a frame on it, we get the information that we need, okay? We fix the big problem, and then we watch her over time with the radiosurgery. She may go to surgery with a smaller AVM. But this is the fun part about these diseases. If you are doing the endovascular, if you have the radiosurgery, if you've taken care of AVMs, bring them together and get this lady so she can go back to school, right? And that's all she wanted to do. So the other thing that's changing a lot is how we treat things. This is one of the suites that we work in at the Clements University Hospital in Dallas. And now we can take lesions on the operating room table and localize them, put catheters where I need to put them, okay, but it's in an OR environment. And then what we're working towards more and more, this is the MRI right here. So if we go back to stroke cases, we can do strokes, bring them in, take care of them, but have all the things kind of co-localized so we're not moving the patients as much. And that's changed a lot of how I'm treating AVMs. Just for time's sake, I'll talk about one more piece on the AVMs, and then we'll move through. But this is, you getting the trend here, younger women, right? A little bit more common, okay, just like aneurysms, okay? But this young lady, her AVM, you see that similar white stuff here? Okay. She bled, had a headache, was sent home, and didn't see anybody for 2 months. Okay. So again, just like the cavernomas, have you seen somebody since, with these findings? And so we brought her in, and this is what an AVM looks like, a little bit. The other ladies was about in here, all right? But these are the larger anterior cerebral arteries going to this, and then this is the artery draining, okay? And we went through a whole bunch of discussions, same thing we went through with the prior person, okay? I had her in the OR to take the AVM out because I thought it was, anterior enough. We took down some blood vessels with embolization to make it easier, so this is what it looked like before. But as I went in there in surgery, this is right down the middle, okay, of the brain. We're retracting the right frontal lobe over just slightly, and we're putting the catheter. All these little vessels are all those little branches off the tree that are going to the AVM. And it got to the point where I clipped one, clipped another one, clipped another one. I took a picture because I had the X-ray there. And when I took the picture, it looked like this. I'm sorry, in surgery. There's no AVM there anymore. Right? And all I had done was gone between the lobes and clipped the blood vessels off. And so I'm in my head, I'm ready to take this thing out, but what am I taking out if it doesn't have any blood flow? And I wouldn't have known that if I hadn't had the imaging right there. I bailed, right? I said, there's nothing to do. She goes home in 2 days after surgery, right? And we're following her up, and this is what it looked like 3 months later. We're done, right? But if you don't have an X-ray right there to look, you're going to say, I'm just going to take this thing out and call it a day. And so again, a lot of fun. And I've debated this a lot. Do you just leave her be? Do you kick it while it's down and just get it out? This lady's back at work. She's taking care of her kids. What am I? And so we'll follow her over time, which we're going to do anyway. Okay. So this is all of this. Talking about AVMs. Those Aruba studies. There's been a follow-up. It's 5-year follow-up. Patients they're still saying do medical care, right? But again, based on the way that they treated the patients earlier, a lot of those it wasn't a very multidisciplinary discussion. AVMs are a team effort. Everybody takes care of them, works through them, talks about them. The neurologists, the neurosurgeons, the radiologists, the primary care docs, right? They're dealing with what happens if she's pregnant. Just like cavernomas, have the baby. Don't worry about the AVM. Okay, but you think it doesn't weird the OB out, right? So, and we have, there's discussion after, vaginal delivery, C-section, frankly, and this is me again. So C-sections are on the OB. They just want their schedule, right? So, but it's okay. Whatever you need to do to take care of the mom and the baby, you do that. There's a lot, National Health Service in Britain, the Netherlands, same thing. They've looked at pregnant women with AVMs, no difference in terms of delivery, right? Or rupture risk, if you haven't ruptured. Okay, once you've ruptured, it changes everything, right? But the chances of you rupturing is not any higher. Okay, so again, play with them, right? Have your opportunities here. So I'm going to pivot real quick. Any questions about that so far? How's my time look? 13 minutes, not 13.4. So, okay, so all right. So, any questions about that? About just AVMs or cavernomas, angios in general? Because I'm going to get into one more topic briefly. Mm-hmm. And you, yeah. So, it's a great question. That's like a 45-minute clinic visit, right, talking about things, and I'll give another anecdote. 3 weeks ago, young mother of two, female, obviously, with a brainstem cavernoma, right? So it's in there. She's got some arm numbness. She's already been operated on by an orthopedic surgeon for carpal tunnel. Wasn't carpal tunnel, right? But has this every time. OCD and anxiety disorder diagnosed, right? So every time she has a numb hand, right, she's worried about her cavernoma. And her uncle is the chief of neurosurgery at one of the big programs in the country, right? So that's what's sitting in the clinic, right? But her cavernoma is in the pons, and it's about a centimeter deep tissue, right? I'm not going after it. If probably the reason that she's having the symptoms is because of her psychiatric diagnosis weirding her out about, right? And so we've had 2 visits now in the clinic that to basically talk about carry your pictures. And what I tell the patients is if the symptom complex is the same but less intense, it's probably the same lesion. Right? That's just a reactivation of the prior stroke. If the symptom complex is different, you should be in the emergency room with your pictures, right? If the symptom complex is the same but more intense, same thing, right? But more times than not, it's the same symptom complex that's less severe, and if it's deep in the brainstem, we're just going to walk you through it, right? Now, would her psychology be helped by the fact that she knows that it was radiated, right? But it's in her brainstem, right? And the chances of an effect from radiation in the brainstem are super high. But there is a psychology of all of this stuff that all of us have probably interacted with patients with brain lesions. That's not in the textbook. That's just being a doctor, right? So I hope that answers your question. It's each one is very, very different. One of the Samson used to say, it's like once you've seen 1,000 AVMs, you've seen 1,000 AVMs. That's it, right? But everyone's a little bit different. Where it is, how they present it, how they're tolerating the knowledge of having the cavernoma or the AVM, right? All that comes into making some decisions about it. But make sure everybody's together. You should be talking, because the primary is getting it from these patients. Right, and they're going to send them to me, right? But then I can't see them because everybody should be talking about it and making sure they're cared for. So, does that answer? Right about, yeah. So, other questions? Yeah.
For your 27-year-old, embolization and radiosurgery. So, do you do the radiosurgery first? The way you were talking about it, you were kind of saying embolization first, but if that's supposed to be an adjunct.
Sure. Great. Excellent question, right? So things have changed with that, okay? And so I was in a we were in international meal. Everybody there did the cerebrovascular disease, and I said, all right. So when we had, you do the polling questions, and you can hit your thing. So I said, so we have an AVM, and for how many of you would embolize and treat what's left with radiosurgery? Okay. 50% of them said they would treat what's left. The other 50% of them said they would treat the whole AVM. I was like, why'd you embolize it then? Right? Because the whole goal for embolization with radiosurgery would be to, one, take care of the risky lesion. That's what we did there. Okay? Because I'm worried she's going to bleed. Radiosurgery works 3 to 5 years out. Right? So take care of the risky lesion. Or decrease how much radiation you have to give them to decrease the risk of the radiosurgery procedure, right? But if if there's not a risky lesion and you're going to radiate the whole thing anyway, then do the embolization first. The radiosurgery first, and just leave it be. If you think you're taking out a risky lesion so they won't bleed in the 3 to 5 years you're waiting for the radiosurgery to work, then embolize first. Right. What we don't know, what I'd like to understand, is the agents that we use. Are they helping the radiation, or are they blocking the radiation? Right. And can you imagine how much investment in research, different topic, that it would take for me to take pigs and keep them up in the veterinary space for 3 years, waiting to see what happened. Right. I started that, and then somebody ate my pig. So it was different discussion, but yeah. So, but no, that's a great question. That probably 2004 or so, that embolization for radiosurgery kind of flipped. Most people now treat the risky lesion, radiate if you're not. So, I saw some other questions over here.
Are the risk factors for these young women increasing, or are they just accessing testing more frequently? Is there smoking, or anything else that's a risk factor that is good to know about?
Yeah, generally speaking, smoking is a risk factor for any vascular disease, right? Smoking, illicit drug use, right? Blood pressure spikes, that's when but a lot more MRIs. Right. I mean, at this point, you get a headache, you get an MRI, and it's the whole thing. All migraineurs don't have AVMs, right? So they don't get it, and they don't get MRIs. But there's a lot of migraine patients who eventually get, and that's what I have to get into the clinic. And they, well, my PCP never got an MRI on me, and I'm like, yeah, classic migraines. It's not their fault, right? But that's the back and forth. So I don't think risk factors for AVMs are changing. We're just finding more because we're doing more imaging, right? I saw another hand over there. Okay, not so much. I don't know if I have time to go into the fistula discussion. So let me give you just a quick, because fistulas come up and they're kind of fun to deal with, and they kind of complete this discussion. Angiomas, funny thumbs, cavernomas, raspberries. I like raspberries, right? So AVMs, probably should worry about those in counsel. Fistulas are the interesting ones. One, because not a lot of people think about them, right? And the difference between an AVM and a fistula is the AVM's got the nest. There's a nest of blood vessels in there. AVMs are likely congenital. Fistulas, the word fistula means miscommunication of two spaces. You've got a tracheoesophageal fistula, you've got a biliary, So arteriovenous fistulas, frequently dural arteriovenous fistulas, some happen to make those vessels misconnect. Okay, so you get pictures like this where everything coalesces on one thing. Now, you could look at that and say, isn't that an AVM? Right? My rule is the funnier it looks, the more likely it's a fistula. Right? If I'm confused, I'll go fistula first. Okay, but causes for fistulas, trauma, right? There's a lot of discussion about thrombotic disease, so malignancies, right, that cause thromboses. A good way to talk about a fistula is not call it a fistula because nobody knows what that is anyway. Call it a shunt. Because that's really what's happening is blood is shunting from one place to another in a abnormal way. The more we learn, and there's a whole other lectures about venous disease, because that's really where a lot of what we're doing is going. But there are channels in the veins that open up if you need them, right? So, in our increasingly obese world, okay, diets, thrombotic, chelating diets, fad diets, dehydration, right? Thromboses, or we see sagittal sinus thrombosis and things from that. Long term, we're seeing fistulas kind of come up, and when we test patients for hypercoagulability, 20% of those patients have some sort of a hypercoagulability disorder or condition, okay, that is now, blood is shunting in a weird way. So I used to say it was just trauma, but I'm very suspicious that there's other medical conditions leading towards the fistula. The difference between an AVM and a fistula is AVMs are seizures, hemorrhages, headaches. Fistulas are headaches, pulsatile tinnitus, right? So pulsatile tinnitus is not the 70-year-old who's got ringing in their ears, or the 50-year-old who's at concerts a lot and has ringing in their ears, right? The pulsatile tinnitus is that shh, 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 right? And we're now, you can see recordings online and things like that. But that used to be a common reason for patients getting referred to me from otology and things like that, because they've got this pulsatile tinnitus. But pulsatile tinnitus, first thing you want to make sure is you don't have that misconnection, and it's like a river flowing into a lake, right? And you get all of these different, but again, fistula is a misconnection. This is a fistulous AVM, just to make it more confusing, right? Because there can be direct connections within an AVM, but there's a nest there somewhere, a nidus, okay? And then that's an AVM, okay? And just what's happened a lot with the fistula is probably the goal in the fistula and the need in the fistula is to disconnect it, all right? So misconnection of an artery and a vein without a nidus, you take the misconnection out, you're good. Remember, you can't do that in ABM, right? Drain and the faucet. But so more and more and more, 70, 80% of the time, we can go through the groin or through the wrist, put a catheter in there and glue those off, and we're done. So that's a big difference. I just told you, don't try to cure an AVM. You should try to cure a fistula. You can. Okay. Now sometimes we try too hard with radiology, where we should come back to surgery, but working both of those together. So if we're talking about this in the context of just in general trauma, malignancy, thrombotic states, inflammation, long-term infection, right? Those are all things that you go back in your history. If you got that pulsatile tinnitus and you've got someone who just got off a chelating diet and lost 150 pounds, plus minus Ozempic, right? So, with this pulsatile tinnitus, is there something going on? Do I need to think fistula? Common diagnosis of a fistula is 6 months from the symptoms, because no one's thinking about it, right? And these are cranial. It's even worse with the spinal fistula. Your guy that comes in with the burning legs and everybody thinks it's lumbar disclaudication. Common to diagnose is 6 to 9 months. And the spinal fistulas, they're in a wheelchair by the time they hit our clinic, right? Because everybody's been treating their disc, right? So I'm mentioning fistula, just kind of think about that. I won't get into the classification systems too much, but at the end, the biggest thing with a fistula is look at that big vein here. When the vein gets dilated and responding just like the AVM woman, okay, that's a high risk feature for a fistula. All right, so a dilated vein with pulsatile tinnitus has probably a 40% chance of bleeding in the next year. Right, so it's a higher grade. Okay, and the way that we treat the fistula is more and more just go in there and disconnect it. Okay, and that is something that should be done. With is there a neurosurgery way to do this? Is there an interventional way to do this? But really disconnect it. And let me show you one little fun thing here. This is another kind of playing with both ways to do it. What I used to do a lot, I'm sitting there for 6 hours in the angiography suite trying to get into the vein to disconnect it. Okay, but I made a rule, right? If it takes me more than a couple hours to go someplace through the groin, I'm going to find a way to get there through the head, right? Because so this is a case where we actually we made a hole over the sinus. right? We placed, this is an angiocath, right? We just placed an angiocath directly into the fistula, right? Because we had the imaging to tell me where I was. And then we just directly injected there. That's, you know, probably 2 hours of surgery plus, and then then you've disconnected it, they're done. Okay. And so there's a lot of that going on, and that's it's a fun way for us to, again, merge the topics together and take care of these patients with these complex diseases. So I think I'll stop there, okay? And thank you for having me. Hopefully I said something different today, and not in English. So, and I'll see you all throughout the day. Thank you.